Welcome back to Rhythm Interventions Online 2025, Day 2. We are now approaching Session 3. We will be going to Hamburg, Germany. This next session is called Balloon and Basket Versatility, Expanding Ablation Strategies with Confidence. And another live case, we're going to have Arian Sultan and his team at St. George Heart at the Asklepios Klinik in Hamburg, Germany. Take us through this beautiful case. And as we go, we always have a team of live panelists. We are welcoming back Brad Knight. We are also bringing in Roland Tilz from Lübeck, Germany, Sri Sundaram from Colorado, United States, and Diogo Cavaco from Lisbon, Portugal. I'll now hand you all over to Arian Sultan and his team to lead us through case number 3.
It's actually her team, but that's fine. A warm welcome from Hamburg, and may I quickly introduce the team who's going to perform the case with me today. So on my right side here is Mrs. Krüger from Abbott, Dr. Demeter from our team, Dr. Wahidi from our team, one of our top nurses, Sabine, my co-head of the department, Dr. Vogler, in the back, Mrs. Lindhorst, also from Abbott, and on my right side, one of our other top nurses, Gesa. So Rahin will give you a very quick introduction of our patient who we're going to treat today, and then we're going to jump right into the case. And please, at any time during the procedure, if you have questions, you want to ask something, interrupt me, we will discuss it.
Okay, so this is a case of a 76-year-old female patient who is suffering from persistent atrial fibrillation. The first diagnosis was in May of 2024, and she has a CHA2DS2-VAS score of 3 points, given that she is above 75 years old and is suffering from arterial hypertension. She's on oral anticoagulation with edoxaban and is symptomatic on an ERA scale 2B with shortness of breath and palpitations. And the echo data revealed a normal left ventricular ejection fraction and a moderately dilated left atrium.
Okay, thank you very much, Rahin. So we already did a little bit of mapping to save us some time. This is not my normal workflow when we go for a PVI using the balloon catheter. So this patient, as Dr. Wahidi mentioned, never had an ablation before, but we kind of had the feeling older women, a small person, she might have some substrate, and I'm just going to share with you how our workflow in this patient is. So as I said, this is not my workflow. Normally we would go mapping on the fly, so do the veins and just map while we're doing it. In this case, we did a little bit of mapping before. And as you can see, we could detect some substrate on the anterior wall and also on the posterior wall. And you guys can already think about what should be tackled after doing the PVIs, because in this patient, we might even tackle substrate outside the pulmonary veins. So, but having said that, I'm going to start with the left superior pulmonary vein. You can see the wire is already in the left superior vein. And what you want to achieve with the balloon here, accordingly to cryo procedures, you want to have good contact. And in this Vol technology, you kind of have a circle that indicates you if your electrodes are in good contact, poor contact, or no contact at all. You see those blue bars, which means like ideal contact. Then you have some bars moving out of the second inner ring. That also indicates you that these electrodes are in contact, and depending on respiration, sometimes our patient is in deep analgo sedation. They also turn blue, and there are maybe 2 electrodes, actually just one electrode number 2, which has, I would say, poor contact because the bar is almost not moving at all. What I'm trying to do here is maybe improve the contact a little bit to get all the bars moving. So you turn the catheter a bit around to see if you can improve something. And here we go. I like that. So almost all electrodes are in contact. So let's get the first burn, please. Also, I have to mention, we tried to cardiovert the patient. The patient had 2 sinus beats and then went back to AFib. So this also kind of reassured us that we should go for potentially more than doing PVI in this patient. We are aware that the data is actually lacking to do more than PVI only in those patients. But again, we I mean, it's an old lady. She doesn't want to have too many ablations. So we are aiming to, get potentially the best outcome for the patient in the first procedure. So also what we do here is that we are using, so we started, and that was a recommendation by the company to, to do at least 2 applications, but in our workflow, we switched to do at least 4 applications per vein. I think this is what the vast majority of users is doing these days. And you can now nicely see in the EnSite map that we're creating not only these dots, but these little E-fields. And this is, ongoing research if this E-fields translate somehow in durable lesions over time. So what else do we do is we kind of turn around and try to get an overlap of the splines. And you can see that the upper part is very well covered with blue dots. The lower part, the contact is sometimes poor, which is okay for the left superior in this case, because we're going to go to the left inferior and therefore also tackling these areas. Go, please. And this was number 3, as I counted correctly. So we will have another one. And according to, let's say, cryo procedures, I tend to bend the catheter a little bit to go to the inferior part of the pulmonary vein, tackle the superior part, and also, torque the sheath a little bit anteriorly or posterior to really cover all areas that might not then have tackled by the direct approach, so to speak. So we can see that this might even be better here in the posterior. Let's go. And the beauty is also is, and this is what we have to discuss in a few minutes when the PVI is done, what we want to tackle. So if you want to go for the posterior wall, we can do that. We can do a roof line. We also did anterior lines and CTI ablation, because the beauty of this balloon is that you can selectively choose the splines and turn off splines who are not in contact with the tissue. So this is something I think very helpful if you want to use the balloon outside the pulmonary veins, because hemolysis, etc., these things can be omitted by doing it potentially that way. So this should be the left inferior. And you can see that I'm not deflating the balloon to go to the left inferior pulmonary vein. Yeah, that's it. Because, I mean, this is a small lady, and even in these not too large left atria, it is feasible doing that. Look at this, that looks nice. Here we go. All electrodes are in contact, all almost blue, except for 2, number 2, number 4. But this is fine. They're very close to each other, the left superior and the left inferior. So therefore, we are creating some overlap. What I also like, I always like to have like a radial view. Am Wiederholen mal ausmachen. And also, we're gonna go for the anterior part here. Und Propofol mal 5 Punkte reduzieren. Okay, and this is not a good position, so we find another position here. Same position as before, just gonna turn the balloon a little bit. Okay. Einmal Atropin bitte. Our patient is a little bradycardic in a moment. So we have to overcome this. Einmal den Kopf und S-March machen. We have to look for this respiration. And then we're gonna give another application here. Go.
Arian, your wire's in a different branch, a lower branch, but the map resembles a common ostium. Do you think that's common?
Yeah. We're gonna have a second look just to make sure that we didn't enter the inferior part of the superior vein. We just have to see that the blood pressure is a little bit low right now in the moment, so we have to double check for that. Let me see if we can go to the upper part again.
Ariana, can we go back a little bit
Adrenol,
about the
bitte.
map? Did you make the map with the Volt? Or did you make it with another catheter?
Yeah, that's a great question. So we did it with the Volt catheter. All was done by the Volt catheter. And you can see I might have been in the same pulmonary vein. So we only used one catheter for the whole procedure. And no, that's the inferior one. So I'm pretty sure in the left inferior vein. So we did the mapping with the same
Can you take us through the
catheter.
voltage settings there?
Yeah, so we use the same voltage settings that we might use with a different catheter, so to speak, to see what's going on here. But obviously, we need, yeah, well, maybe we can show the voltage settings here. Yeah, it looks like a common ostium, though. You're absolutely right. You can see now we are oriented a little bit more inferiorly. I have to look 1 second at the patient. She looks good. Yeah. So that's what we actually have to learn, right? So if the balloon, the settings that we, or the voltage that we encounter with the balloon are the same that you might encounter with different mapping catheters. Yeah.
Well, I think clearly the electrode
And
space
are you-
is going to be different on this
No,
than a
stop.
grid, right, Sri? And
Yeah, I mean, obviously a grid
that actually
might have
creates
different settings and different settings for that. So this might be obviously a different thing. But again, this is something that we have to learn here with the catheter. Okay.
Hi, Ari. It's Roland from Lübeck. May I ask,
Hi,
did you
hi,
have
hi.
angiographies of the veins before? Hi.
Good question. Normally I would not, since I think you can achieve and reach all the veins with the balloon. Obviously you might overlook a vein, but to be honest, I always, look with a wire to find all the pulmonary veins in the patients. So to be honest, don't do it in a vast majority of cases.
And concerning the superior vein, you did 4 applications. So actually what our typical approach would be, and it looks a little bit like a common ostium, I would have done 2 deep applications and then just pulled the balloon more back and 2 more antral applications to get a larger area isolated. So what's your approach? You stay with the same level and just want to get it very deep, or?
Yeah, I mean, there is actually the Frankfurt group, I think, is working on the so-called peer approach accordingly to their what was it called, olive approach. And I don't know. I mean, if you isolate a vein very antrally, give me just a second. We have to get some saturation from the patient. Haben wir irgendwo einen Sättigungsclip jetzt mal? So we trend to go more for the antral part, because I mean, if the vein is isolated antrally, I don't know, it really doesn't matter what's happening deeply in the vein. I mean, there is some theory that you might want to get the sleeves more distally, but again, I mean, if a vein is completely isolated anteriorly, that should be fine as well, right?
Yeah, sure.
That's good.
No, I mean, to isolate at an even more antral level than you did, just we would typically go back, rotate more posterior to get an even larger antral lesion in large osteo like
Yeah.
this ones.
Yeah. That's what we're gonna do right now as well.
Okay, perfect.
We have another application here. Let me see how the contact is. Yeah, go.
Hi, this is Diogo from Lisbon. This patient is in sedation, right?
Yeah,
I
and
think
deep and
today.
algo sedation.
Okay. And how do
Yeah,
you
that's
compare
our-
this
that's our
system to the others. Mm-hmm. Is
Pardon?
it easier with this system to have the patient in sedation? Is it?
Yeah, I
easier
mean,
with
I
this
don't want
system
to.
have the
I
patient
don't
in
want to over
sedation
advertise.
as compared to
I don't want to
the other?
over.
Okay.
Yeah, I don't want to over advertise, but yes, to be honest, it is a difference compared to the other systems. Patients actually almost never cough. We never see any coughing, and this is clearly something different. And yeah, I have to say, this is better. It definitely is a difference.
It's also
And I
very
think also
dependent.
Roland has-
In my experience, it's very dependent on the patient. There are patients that tolerate it very, very well, and some.
I have to say, I mean, we did now over 30 patients, and I have to say that,
Mhm.
to be honest, in the vast majority of patients, we have the same experience, that it's very easy to perform, and we don't see any coughing in those patients. So that's quite quite easy to, so to speak. Yeah, go. And you can see while I was talking to you guys, we already switched to the right side. So again, we never deflate the balloon while we're moving around in the left atrium. Only, and you're going to see that in a minute, for the right inferior pulmonary vein. In the vast majority of cases, I have to deflate the balloon, pull the catheter back into the sheath, sometimes completely. Look at this, look at this, look at this, look at this. The patient
Nice.
terminated into sinus
That
rhythm.
restoration of sinus.
So
Beautiful.
we are
Oh.
very, very, very happy with that. So maybe we can even
Right.
spare the
Are you
patient
saying it was a
more than that?
It was a delayed termination. It was a delayed termination,
Yeah.
wasn't it? If we could go
Yeah,
back
yeah,
to
of
the
course.
screen. It was
Yeah.
like a type 2.
Maybe you
or
go a
type
little bit
3.
more
I
back.
think I completely agree with you. I think with the volt balloon for the left-sided vein, you see hardly, and so you know, no coughing and hardly any contraction. And for the right-sided vein, you see some contraction, but only minimal contraction. So maybe you fluoro during the application of the right-sided veins to demonstrate how little the patient moves. I think this would be very interesting.
Yeah, here. You can see that. So this is the right side. I'm
We don't
filming
see
right
the fluoro
now.
at present time because we only see
Oh,
left
maybe-
times.
maybe-
you change to the fluoro.
Okay, maybe we can change to
That's
the
very
fluoro
impressive.
screen, please.
Yeah,
Patient's
no.
going in and out of
Please.
AFib. So let me get good contact and then we give another application here. Okay, go. And you can see here, now I'm filming while we are ablating and you can see barely not moving. There might be a teeny tiny bit of phrenic nerve capture, but that doesn't concern me too
Yeah.
much. We never experienced any adverse outcomes.
Now, are you steering
Why
the
do you
catheter mainly
address
with
the
the sheath
panic
or
nerve?
the catheter?
Pardon? What was that?
Oh, go ahead, Roland.
Are you steering the catheter with the sheath or
maybe-
the catheter? I think was the question.
Oh, I'm only steering with the sheath, so to speak. I mean, I'm barely moving the catheter. There is like a little handle on the catheter as well. You can switch between a D and F curve kind of shape, but I mean, I in my experience, we actually always get everything achieved by only maneuvering the sheath and letting the catheter hang out there. Go. Or was that a different question?
So may I ask you, Ari, concerning
good,
the
thank you.
protocol, part of the Volt study protocol was that you pace from each electrode at the right-sided veins, and if you get phrenic nerve capture, you reduce the output from 1800 volt to 1400 volt and deliver 3 instead
Yes.
of 2 applications in order to be even more cautious. We still follow this protocol, but it appears that I mean, now everyone can do what he wants, and I think many operators or some operators pace the phrenic nerve and some don't. So obviously you don't, or what is your protocol?
Exactly. We don't. No, we don't do that. I mean, we were doing that like for the one or the first cases, but then we stopped doing that since
Yeah.
we, had the experience that, I mean, we all in the beginning. So we did like 30 cases, but so far no adverse outcome with the less cautious protocol. And so we stick to that. So we don't do that actually. And now I'm done with the right superior pulmonary vein. So we did 4 applications there. And I mean, it appears that it is actually quite antrally because I omitted to go in the pulmonary veins because if you want to get more anatomy of the pulmonary veins, you do have to deflate the balloon a little bit, bring it deeper into the vein, then try to inflate it carefully a little bit in the veins. Then obviously you might create more anatomy that looks most likely like the anatomy that you know from other procedures. But I think to get an idea where the pulmonary veins are, where the ostia are, I think it's fine to do it with the inflated balloon. So you get good impression where everything is. And I think that is completely sufficient to do the PVI. Having said that, I think that leads, and that what we see in RIO procedures, that leads to a very antral isolation of the pulmonary veins. So that's why we also not intentionally try to do even more, let's say, antral ablation. So now to get to the inferior pulmonary vein, I can show you the fluoroscopy again. We are deflating the balloon almost completely. You can see that the basket kind of stays in the shape like it is. And now we're pulling back the balloon into the sheath. This is a little bit rigid, but in this case, it was very smooth. This is, to be honest, not always the case. And now, as you know from cryo, it's a tricky moment to get in the right inferior pulmonary vein. So you just bend the sheath a little bit, and then you try to get in the right inferior vein with your wire, which we were able to do before, and I'm pretty sure we will be there in a sec again. Oops. You can see that can be a bit tricky to get in there, but normally, when we were doing the map, that was like a first shot in. Yeah, there we go. Just gotta confirm in the RIO projection. As we know from all the other procedures, you can see nicely the wire now is in the right inferior pulmonary vein. And now over the wire, I'm gonna advance the balloon towards the vein. Now you can see what I was talking about, right? So now the balloon is deflated and is deep in the vein. So if you would collect anatomy right now, can we do that? So now you can see that we are able to collect nicely anatomy, as you might know it from using the H2 grid or something like that. But again, I think for a PVI only approach, this is completely sufficient not to do that and stay outside of the pulmonary veins. So now I keep the balloon, let's say, quite oscillate. The tip might be even in the pulmonary vein. And now I'm going to inflate the balloon again. I'm just going to film it that you guys can see it. Fluoroscopy, please. Can you see that? So now the balloon is inflating again.
Yeah.
And you can already see the bars getting in contact with the tissue. And again, the right inferior, as we know it from other balloon technologies, might be sometimes a little bit tricky to get in there. But again, in our experience so far, absolutely comparable with other technologies that we use so far. So I like this. That looks like almost very good contact. Go. Just electrodes 7 and 6 might not be in ideal contact. These are the ones who are posterior. So for the next application, I might turn the balloon a little bit more posteriorly and inferiorly to get more contact to that. And I always, as I said, on the right plane, you can see that like a radial view on the balloon itself. So I can tell which electrodes are actually in good contact and which ones are not. And now we are bending the catheter a little bit more. As I said, I'm going to turn the catheter a bit more posteriorly to bring those electrodes who were not in contact at all into contact, pulling down the catheter a little bit. And then now go. All bars are moving. So did you already made up your mind? Should we go for posterior wall isolation? Should we do an anterior line? Should we go for a roof line? Or shouldn't we do anything?
Let's take a quick poll. Does the termination of this beautiful persistent fib during vein isolation dissuade or persuade someone to do additional? Let's go to Portugal.
But also keep in mind the
Cavaco.
voltage map that we had, right?
Yeah.
Exactly, and then we can
I would do
certainly
posterior wall
editorialize
isolation.
how voltage plays in. You would do posterior wall from Dr. Cavaco. Roland Tilz?
Yeah.
Yeah, I think you have low voltage in the posterior wall and persistent AF. I would go for posterior wall isolation.
How about the anterior wall? Doesn't look too nice either, right?
We are about to randomize the volt balloon with low voltage versus no low voltage, and there we would also ablate the anterior wall. But outside study, I think we don't have enough data just to do anterior wall, posterior wall, and everything is the first two. At least that would be my approach. Within study, yes. With outside study, I would only do the posterior wall.
Well,
I
we
guess
get
that's
Dr.
a fair-
Sundaram's vote. Can you guys show us the voltage map posteriorly?
You know, I don't think
There we go.
termination has
That's
ever
the
really been shown
posterior.
to be a really good endpoint. Termination has never really been shown to be a good endpoint. So I would base it on voltage, and a persistent with that heterogeneous voltage, I would do the posterior wall. I don't think I would do the anterior wall. That's the area that does the most, contraction in the left atrium. So I'd probably leave that alone for now.
Yeah, that's
Brad
I
Knight?
think that's
By the
a
way,
fair
I mean,
point.
Another
I mean,
question that I think it's interesting. Sorry.
go ahead.
I think
Something Well, something that I think it's interesting is how low should we go on the posterior wall? Up until should we go until the coronary sinus, or should we stay on the lower just on the veins?
Yeah, that's a good question. To
That's
be
a
honest,
great
I
question.
like and I tend to go inferiorly because I don't know. In my
Me too.
pathophysiological understanding is these patients often have hypertension. The posterior wall is fixed to the tissue, so the posterior wall can only extend to a certain extent, so to speak. So what happens is that the left atrium is expanding anteriorly and inferiorly. So I think this might be a fibrotic area that we do have to tackle to get rid of it. But again, data is not completely proving that yet. But that's at least my approach. Okay, one view from the posterior.
Let me editorialize a little bit with some evidence base while we get a lot of
Yeah.
opinions, because for 2 decades, it's all opinion and anecdotal based. If you look at Erase AF by Piotrowski in New England Journal of Evidence, that's the only study that's really shown ablation of low voltage areas could be useful. And they actually did lines. So I don't know if you can do an anterior line with this that's durable with this platform. Number 2, DCAF2, which was very promising, failed to show that, but they didn't do lines. So maybe that was something arrhythmogenic. They were doing more spot. Minglong Chen has done stable SR 1 and 2 and not been able to show that ablation of low voltage zones has improved beyond PVI. So the wealth of evidence would suggest not doing, this is just for evidence-based for our audience, would really be to not do anything with voltage-based. Now, because we have time and Dr. Sultan has breezed through so beautifully, I'm going to personally request you to remap right now with the current mapping catheter in sinus rhythm. And then we can also opine about the value of a voltage map. We all know that this is a wider spaced electrodes, et cetera, during sinus versus AFib. But if you wouldn't mind remapping, touching down the vestibule.
Yeah, we would, if
which
it's
is
okay
very
with you
well
guys, I
addressed.
would first go for the posterior wall and then do the remap.
I would like to see a remap before you do the posterior wall in sinus rhythm, because we're talking about the fact that the posterior wall has low voltage. And then
Yeah,
since
we can do
have
that. We
time,
can do
Dr.
that.
Sultan, we have time and we're not in a hurry. We still have about 25 minutes here, so we should just
Yeah, no
milk
worries.
and
We're gonna
enjoy
do
all
that.
the discussion, the
Okay, let's
physiology,
do
and
a
being able to see
remap.
things in real time.
And just to
Maybe,
answer
I
your
mean,
question
one thing-
before, it is feasible to do an anterior line with this catheter. So we did that already in a few patients. But again, it's obviously not ideally shaped for that. As I said before, you can choose the splines and therefore you see which ones are in contact with the anterior potentially line you want to create, and therefore you can turn them off. These ones who are not in contact, and you can create a line, but obviously it's not comparable to a point-by-point catheter ablation line. So we're going to do the mapping and you guys can continue asking me questions. I'm trying to do that on the fly. As you
Yeah,
can see
and
here.
while we're mapping here and we're just doing some detailed mapping of the vestibule, I think as discussed by Dr. Cavaco, he was saying how low do we go? Vestibule is the thickest part. That's the part Convergent does very well with. It's hard to get transmural in the vestibule, and how low do we go is a good discussion. But can I get Dr. Cavaco your thoughts on voltage mapping during AFib versus sinus rhythm?
I think that the option of remapping is it's very good, because many times we see normal voltage after remapping in sinus rhythm. So we'll have to see what we have here, but it happens many times, and so remap is and we are seeing that we do not see as much low amplitude signals as we were seeing
Das rechte von vorne.
in atrial fibrillation ablations.
Das
So I
rechte von
think
vorne.
remapping
Dr.
in
Tilz,
sinus rhythm is very important.
thank you. And Dr. Tilz, you wanted to do the posterior wall because the voltage was low. Does this dissuade you? And thank you for entertaining me by remapping.
My pleasure.
Maybe one thing that I would like to highlight, I mean, what people often say is that blue means good contact and white means poor contact. And it's extremely important to highlight that as soon as the electrodes, as 50% get into contact of the electrode, then it gets blue. So if you get in contact at the ridge, for instance, or at the carina, typically you would not get 50% contact because of the anatomy. So you might get still very good contact, but a white electrode. So you always have to keep in mind what the anatomy looks like. The other thing what you also have to look is the bars. So usually if the bars are in movement, if it's white and the bars are moving, usually this indicates that you have a good wall contact. So blue means don't worry. White means look at the bars, reconsider, does it make sense or not make sense?
Yeah, exactly. I mean, that's what I said before, right?
That-
I mean, if you are in blue, that means like you're pushing completely to the tissue and everything is like perfect. But again, I'm always looking at the two circles that you hopefully can see. So you have this dotted line and you have this thorough line. And if the bars are moving towards the dotted line and even crossing this dotted line, then you are good. You are in good contact. So this is something, and you're absolutely right, Roland, in pointing it out again. This is something that you have to consider. If the bar is not moving at all, like right now you can see, because I'm like here in the infrareceptal portion of the heart, only 2 bars are barely moving. So that means the rest of the electrodes is somewhere in the cavum of the left atrium. So this is obviously, if this would be the contact for a pulmonary vein isolation, don't do it. It's not good contact. But you can see the bars as soon as you get in contact. Now I'm turning the catheter towards the anterior wall, and you can see immediately that there are more electrodes in contact. And this also applies for the pulmonary vein. Also, you can see for a safety feature, I always leave the wire a little bit outside the balloon just to make sure that the tip is safe and is kind of protected. The next version will have a shorter tip. That's what I at least learned. So this again might increase safety. But you can see it seems to be bulky, but I can tell you it's really not that bulky as it appears from the outside. When I saw the balloon first, like at ERA 2 years ago, I thought, man, that's really bulky. But once you start working with it, you can really see, obviously it's a balloon. It's not comparable to a point-by-point catheter, but it's actually quite easy to maneuver.
Maybe, may I ask you
Brad,
one question concerning the right inferior vein? I mean, as you highlight, it's a balloon. But the important thing, it's not a cryoballoon, because for the cryoballoon, initially we tried to copy the cryomaneuvers. And particularly for the right inferior vein, we tried exactly your maneuvers. So just pull the balloon back, curve the sheath, advance the wire. But what I realized is that it's sometimes very difficult to advance the balloon if you have a sharp curve. So we changed our strategy, and I always keep the balloon maybe 2 or 3 millimeters out of the sheath and curve the sheath. And then you can consistently cannulate the superior branch of the inferior vein. And I think this is the second very big difference as compared to the cryoballoon. So I would rather cannulate the superior branch of the inferior vein, not the inferior branch of the right inferior vein, and then just release the balloon. I think this makes it much easier as compared to if you make a curve. So what is your experience? Do you have different approaches?
Yeah.
You always follow this approach?
Well, we basically always use this approach. I have seen cases where they use like an upside down approach. They kind of pull the balloon backwards, and by pulling it back, I mean, they do a loop and then pull the balloon backwards, and by pulling it backwards, it kind of flips into the right inferior vein. I think this is also very elegant. I have to say, with this bending of the sheath and having the balloon just at the tip of the sheath, we were able to manage until today all the cases that we wanted to do. But I think there are many different ways how to get there. Just a quick word to the voltage. As you can see, and potentially as expected, the voltage on the posterior wall right now in sinus looks quite healthy to me. There is still some substrate. We could at least discuss that. Is that poor contact, or is that really substrate on the anterior wall? And if I look at the posterior view, let's say the waka between the veins just left a little bit of a roof up there. So right now I would, be thinking something between doing an anterior line, for which this catheter might not be the ideal tool, but it's feasible, as I said, or just give another 2 shots at the roof and close this gap on the roof. Or shouldn't we do anything? What's the opinion?
Can we see the mapping density as well? Can we see the mapping density displayed?
Yeah, can we see the mapping density? Obviously, Do not expect
And
the
maybe
same
just
density
touch
as
that
with
one spot there
grid.
by the right lower.
Well, Rod, you
Which one? On the right
raised an
lower?
important issue. If someone with persistent AF shows up in AF, I tend to ablate them during AF, and I am influenced by termination. It's not common, obviously, but you've shown here a perfect example of how it's uncommon to find normal voltage during AF map those patients. But here's a nice example of normalization of voltage during sinus rhythm. I would be influenced. I've only used a volt in the veins, and it's very tempting to just give a couple more lesions because we can do it so much more easily now. And this is an uncommon situation to terminate like this, but there's not a lot of evidence that doing anything more right now would be helpful.
Not really, but there's some data, I think, from the Frankfurt group and other groups after PFA applications that you have this very antral vacuole lines that a lot of them show up in roof-dependent flutter. So if we have an isthmus, and
Yeah.
right now we don't have a clear cutoff in terms of how broad this isthmus should be to not do anything. But in this patient, I'm a little bit, tending towards doing a little bit of a roof line here since the catheter is already a nice position. But again, if you guys convince me not to do it, I won't do it.
Well, this is a great discussion because I do believe we need to bring mechanisms back into the field of atrial fibrillation. Obviously, it's been wonderful to see the evolution of energy sources. But if you think about why a posterior wall could help, number one, you could really box in a trigger from the posterior wall. But if we all collectively were to show cases where you have a posterior wall firing when you have a box lesion set, it wouldn't be that high of a number of PowerPoint slides. Number two, it could improve the durability of the carina and all the isolation, which I think is important. And the number three that you're bringing up very nicely, Dr. Sultan, is that you're going to mitigate the risk for atrial arrhythmias, meaning flutter, with a potential roof line. So, those are, and then obviously
Exactly.
Andrea Natali believes embryologically, the roofs and the pulmonary veins are the same, and therefore they should just be taken out as the same. So, those are the four reasons for the learners in the audience to understand why posterior wall is even debated. But this is your case, Dr. Sultan, so you do what you will and show us the Asklepios way.
Yeah, so I go because also I promised the patient that we will try to get the most done in the first procedure possible. So can I see the left plane a little bit more tilted, the left one tilted to the thanks to the roof. So I would go and close this gap up there. Obviously, it's not super critical isthmus, I'd say, but I'm just gonna do it. So now you can nicely see that we have a few electrodes in very good contact. This is number 3, 4, and 5. The other ones, the bars are not moving at all, I'd say. So now the beauty is you can turn them off. So to avoid, PFA applications in the blood pool. So maybe we can turn off 1, 2, 8, 7, and 6, please. Okay, and then go. And we're gonna do 2 applications here. And if I do something outside the pulmonary veins, I tend to not completely give a second ablation at the same spot, but rather move the catheter a little bit to give it a little bit of an overlap. But we'll see how that works here in this case. Roland, what do you think? Would you have done the same, or is that over treatment?
Yeah, I think that's very sensible to deselect the anterior electrode. And if you would do the posterior line, I would have done it probably the same style. And I think what is really unique to the volt balloon is you have the flat electrodes. So they're flat and not round. You have the balloon inside, which insulates. And you
3,
can
4,
deselect
5.
electrodes. And that's why you deliver the energy only towards the posterior
Nee, 3
wall.
an.
And we measure the inflammation and the hemolysis, and that's much less as compared to other systems. So you have less hemolysis, less inflammation, and if you use the technology, and the hemolysis and the inflammation is not more if you're at the posterior wall, and I presume it's because only typically 4 applications.
And how many applications do you
Avoid collateral
apply
damage.
if you go? What's your workflow?
Typically
What
4.
are your yeah?
We would typically
we can
do more
in-
antral lesions for the left-sided vein. So pull back a little bit, get the antral lesion a little bit antral, and then add 4 applications at the posterior.
yeah.
4 is usually enough, but
So
only with
on,
50% of
2,
the electrode.
2, 3, 4, and 5 is on. Yeah. And you can see those electrodes that are turned off are displayed in gray, and the rest is blue. And as Roland said, don't think you always need to have like blue. You can see that some of the bars even go blue and white. They change due to respiration. That just means we are still in good contact, but we don't have to always achieve like full contact. Bolus von 2 bitte, Propofol. And there we go for the hopefully one of the last ones. Here we go. On please, 2, 3, 4, 5. You can see these are the electrodes really touching tissue. The rest we're going to turn off to avoid unintentional ablation or PFA applications in the blood pool. I mean, even if hemolysis is reduced, it's not completely omitted by this technology. So whatever you can do to make your procedure safer, I think it's a good tool to be able to select them. And as I learned, all other companies are trying to work on the selectivity again as well. And we do a second one here to close the gap on the roof. Yeah, same bars. Uh-huh. Okay, that looks quite good. So as you can see, I have the wire in the left superior vein. I do that as a safety precaution here, just to be sure that the balloon is with the tip not pointing too much towards the roof. And now just to make sure that we really tackle the complete line, I'm gonna move to the right side and do the same maneuver, or have a look at least from the putting the wire in the right superior pulmonary vein. You can see that here right now. And I'm doing the same maneuver just to double check that we are here on the safe side with everything. Yeah. So can you see the fluoro? So I'm always doing like a little bit of an S shape. So the balloon is towards the right superior vein and the sheath is pointing more towards the left superior pulmonary vein. That kind of takes the pressure from the roof, but also leans the catheter a little bit more towards the roof, but not with the tip of the balloon. So I think maybe a little bit of a safer maneuver to do so. So now we have good contact. 1, 8, 7, 6, and 5, and 4. We turn off. Whereas number 1 is more, yeah, I like that because it's a little bit posteriorly. Yeah, we can turn off 1 and 2, and then we're good to go. Any comments from the panel?
In the vein. I've only used this in the pulmonary veins before. Are you trying to put the front of the hemisphere in contact, or the equator, or which part of that volt balloon are you trying to get in contact?
Well, I mean, the equator would be the most favorable one to put in contact, but this is not always applicable due to the anatomy. So if you have the equator always in contact, obviously you have potentially touching the broadest part of the electrode and the longest part of the electrode with the tissue. But this is sometimes not that easy to perform. So this way, I kind of get, let's say, the distal and the equatorial part of the balloon in contact. But what I want to omit is going perpendicular with the tip of the balloon to the roof. First of all, there is the end of the electrode, so I will have a hard time getting any electrode in contact. Second, there would be the risk of perforation, but I want to omit.
By the way,
How many total lesions do you do for posterior wall and veins?
Depends on the size.
How many total lesions do you do on average?
For the veins or for the posterior wall?
Yes, for the veins and the posterior wall, for both combined.
So for the
In the study, in the initial
vein,
studies, it was 18.5 in the US. Yeah.
Yeah, exactly. And as I said, in the beginning, as told by the company, where we're doing 2, maximum 3 applications per vein. Now we changed our protocol to at least doing 4 applications per vein. Sometimes we end up doing 6 if the anatomy is a bit challenging. And for the posterior wall, we are ranging somewhere between 8 and 10 applications, depending on the size of the posterior wall and how inferior we go. Okay.
In our
That
study,
actually looks
Everyone
we
is
do
not familiar with the balloon.
2 to 3 per vein.
2 to 3.
The 3 more 3 than 2. Usually
Okay.
an extra in the carina.
Great.
By the way,
We
for
can try
everyone
to
who is
do
not
that remake.
familiar with the
7
balloon,
mean
the white and the blue part of the balloon indicates the active electrode. So the very proximal end, so 1/4 of the proximal end, and the nose, then maybe like 10% of the distal end, there is no active electrode. So you do not deliver energy at that part. And if you cover 50% are in wall contact, you get a blue electrode. If you cover less than 50%, it's white.
Exactly.
And per design,
Well, that's-
you're allowed to use it with wire or without wire. The only thing what you must not do is just keeping the wire 0.5 centimeter out, because then it's like a knife. So we would typically use it in most situations with the wire outside, but there are some situations for the posterior wall where we keep the wire inside. What about you, Ari? Do you always keep the wire out, or do you sometimes keep it?
Yeah, I mean, no. I mean, the more we learn, let's say, the braver we might get. For the posterior wall, if we have a large left atrium, you have enough space, then we might even not keep the wire out. As you said, you should keep it short, because then it can be really dangerous. So as I said, for the roof line, as you can see here, I normally tend to keep the wire either the left upper vein or the right upper vein. Again, if it's really large left atrium, sometimes you can pull back the wire. But since we're using the catheter outside the original indication, so to speak, I'm being here a little bit more cautious. I mean, the wire is very floppy, and that kind of makes it pretty safe. But again, we have to be aware that we're using the catheter outside the pulmonary veins, and it's a balloon catheter. It is feasible. You can choose the splines, but still, I think safety should be the most important aspect here if you use the catheter outside.
We use
So you can see now
Doing these
It's
lesions.
a very tight curve.
Are we
Pardon?
going to be assessing roof block? Are we going to be assessing roof block?
was
Or
that?
are we just going to remap and look at low voltage in terms of our endpoints?
Yeah, since
We'll just do a remap.
Yeah. We can do a remap. We can try to do that. So far we only did a voltage remap in those cases, but we can try to pace via the CS and see if we can see propagation. But to be honest, we haven't done that too often with the catheter. But let's see if we can do that live here. Bolus von 2 bitte.
Just
we
for
did
the
that for the
panel, what's the best
CDIs
way
that
for you
we-
to show roof block.
For me, like in conventional procedures, I always do an activation map, for example, via CS pacing, and then do a high density map. And you can nicely see the propagation walking up the way if the roof is really blocked. So this is how we do it normally. Because these days with high density mapping, a quick remap is done really fast. And I think especially in those thickened atria, that's sometimes hard to say by pacing maneuvers. And if you have a propagation map, that's most likely very, very obvious if there is a line of block or not. Wir machen voltage map. Okay, let's see.
Brad, what do
What's
you
your
like
approach?
to
Do you
use
guys,
for roof block? Is sinus rhythm enough with
my
where
approach to
Bachman's
roof
comes out anteriorly?
I'm sorry, how I assess it or how I perform it?
What's the best pacing site for differential
In
pacing
general-
roof block?
Well, if I have a high density mapping catheter that I can straddle the roof and get electrodes on each side, that's, I think, the best way. But
that's a
otherwise,
good point, because
you
as
can
you
try to
can see
pace-
here, you might want to appreciate that. that we have something like split potential see on the volt catheter, volt 5 and 6. You see something like a split potential. So that could indicate that it looks, I mean, the voltage looks quite good, that the roof is completely blocked here. But again, you see the, let's say, short. Go ahead.
I would make the comment that our ablation lines are much wider than they were before. So when we do an ablation, for example, of the CTI with a pentaspline catheter, and we do pacing maneuvers, the stem to A time seems shorter and there might not be block. I think it's partly because we've already eliminated a very large part of the tricuspid annular conduction time. The conduction times that we're looking for might be shorter now than we saw previously with a very narrow line of block.
I mean, we all like as EPs, we all like pacing maneuvers, but in the PFA era, I think we have to confess that it's not a line that we ablate. It's rather, I always call it posterior wall ablation. So we ablate the posterior wall. We don't ablate two lines. It's ablation of the entire posterior wall. And so, to be honest, for me, the endpoint, it's loss of, it's the voltage map, no? We ablate the entire posterior wall. It's a huge area. And at the end of the day, everything is great. But we don't do pacing at the posterior wall anymore.
No, that's true. But you also have to make sure when you do the remaps that you are in good contact, because otherwise you can fool yourself and to be honest, to cheat a little bit and say that the posterior wall is completely isolated or your line is blocked if you're not in contact. So I like the combination if feasible in doing both. So doing a voltage map or propagation map, but also doing some conventional pacing maneuvers. But you're absolutely right. I mean, you can see our setup. We have one balloon catheter, we have a CS catheter. This is something we could debate as well. Some centers got rid of the CS catheter. We still like it because, first of all, we never use TOE for the transeptal puncture, and also I think it's an anatomical landmark for the transeptal puncture. And also in terms of pacing, if you for some reason need pacing, and we do know that patients with PFA might, despite atropine and everything, might react bradycardic, so you have a catheter in place. So we are still using it. It's for us not very expensive. So. But I know there are centers just going for a single catheter approach which is also feasible. So just getting back to the map here, you can see that the anterior wall, despite having sinus rhythm, as you can see, also nicely described by Andrea Sarkozy in her studies, that in those older women, the anterior wall might be something that we should target. So for the next procedure, I might target the anterior wall in this patient, to be honest. The posterior wall, and this kind of makes my point a little bit that I'm against this completely pragmatic, all posterior walls should be isolated. As you guys nicely discussed, the posterior wall in this patient is completely healthy. So despite all the embryological considerations, I think this is one of the reasons why we don't see the complete clear data on posterior wall isolation, because a lot of these patients who are receiving posterior wall isolation might have completely healthy posterior walls. And to my EP understanding, I never get why I should tackle completely healthy tissue. If you would go for conduction delay, something like a functional map of the left atrium and see some abnormalities there and then go for posterior wall isolation, that's something I would understand. But let's say a very pragmatic approach and doing posterior wall isolation all the patients, I don't think that really does the trick in all the patients. So in these patients, as you have nicely seen, maybe tackling some low voltage area and the anterior wall might have done the trick, or will be something that we have to do in the future.
Well, we've got about 1 minute left, and I think that you've done a beautiful job with your team of showing us an almost effortless workflow in getting these veins isolated, and then showing us live at termination during isolation of the RSPV, and then having a nice discussion of the posterior wall value. And of course, it's controversial. We've been talking about that for 20 years, and seeing the different takes on voltage. I would also editorialize that if you keep a mapping catheter during atrial fibrillation longer in one area, voltage starts normalizing. So if it's quick sweep across, AFib is always lower voltage than sinus rhythm. because you have this fibrillatory cancellation. But if, as we all
Yeah.
see, the voltages are highly variable. So the longer you keep it there, and I think Jeff Lee has shown that, if you keep it there for 5 seconds, the voltage maps start looking more and more similar. Believe it or not, and those that don't believe it, try it for yourself. But I want to thank you and congratulate Dr. Sultan and her team at St. George Heart Center, our panelists. Great comments from Brad Knight, Roland Tilz, Diogo, and Shri. Thank you so much. Lots more to come on day two. Stay tuned with us. Congratulations again to Hamburg.
Thank you very much. Thanks for having us. It was our pleasure. And we wish everybody who's
Thank you.
watching a very nice Congress. Bye-bye.